Minimally invasive endosonographic trigger thumb release. Brian Gerbala, MD, Highland Center for Orthopedics, Lakeland, Florida. Indications: symptomatic trigger thumb in individuals unresponsive to conservative measures such as splinting and steroid injections. Contraindications: previous trigger thumb release or prior surgery over the palmar aspect of the thumb, patients with Dupuytren's disease, rheumatoid arthritis, and/or active flexor tendon sheath infections. Setup: a high-resolution ultrasound unit with a 12 to 18 MHz high-frequency probe, a guided push knife, sterile prep and drape, sterile probe cover, flat iris-type scissors, Adson pickups, a number 15 scalpel blade, 10 cc's of 1% lidocaine with epinephrine. The push knife device consists of a long ball-tip probe measuring approximately 2 centimeters, a dorsal ball-tipped outrigger guide, and a microtome cutting blade. Prior to the case, the surgical site is verified and marked in the pre-procedure area. Prior to prepping and draping, the patient is injected with 5 to 10 cc's of 1% lidocaine with epinephrine directly into the area about the proximal, and proximal distal thumb crease, with half the volume being injected directly into the tendon sheath under ultrasound guidance. A timeout is performed, and triggering is verified clinically prior to the procedure. A sterile probe cover is applied. These probe covers come in kits with sterile gel and sterile rubber bands. Non-sterile coupling gel is used inside the probe cover. An adjustable microphone stand is useful to suspend the probe over the surgical field. 2 sterile rubber bands are useful to hold the probe cover in place. As an alternative to rubber bands, tape can be placed by the assistant at the top of the probe cover to secure it. Our landmarks for the procedure will consist of skin surface landmarks and sonographic landmarks. Skin surface landmarks for the procedure are based on those described by Hazani et al. The proximal thumb crease and the distal proximal thumb crease. This interval will contain the A1 pulley. The 3 mm skin incision will be made just distal to the distal proximal thumb crease and just radial to the midline. Next, we'll locate our radial digital nerve crossover. This is found by obtaining a cross-sectional view of the flexor tendon sheath and neurovascular bundles. We scan from distal to proximal, starting at the level of the A1 pulley and scanning approximately 2 centimeters proximal to the proximal thumb crease to find the crossover within the thenar musculature. This area is then marked and noted with our marking pen. Next, we'll locate the hook of our hamate, which will mark the trajectory of our flexor tendon sheath and knife blade. We start at the ulnar proximal wrist crease, locating the median nerve, the ulnar artery. We then scan proximal to distal, following the ulnar artery to the hook of the hamate. We then mark the hook of the hamate with the marking pen. The thumb flexor sheath and corresponding knife trajectory is found by drawing a line from the incision to the hook of the hamate. Our radial digital nerve will cross this line approximately 2 centimeters proximal to our proximal thumb crease. Our safe zone, which is approximately 2 centimeters, will be between the proximal thumb crease, and our crossover point drawn along the line between the hook of the hamate and the incision site. A long-axis ultrasound view along the flexor tendon sheath will confirm that our line was drawn along the correct trajectory. Reviewing, we want to find our distal proximal thumb crease, our proximal thumb crease, and our A1 pulley will lie in between these two. Our incision will be just radial to the midline and just distal to our distal proximal thumb crease. We'll scan transversely until we find the crossover point of the radial digital nerve, and we'll mark this. We'll also locate the hook of our hamate with ultrasound. Then we'll draw a line connecting the 2 points. I'm going to go ahead and mark some things out here on your thumb. So this is her thumb, her proximal thumb crease, proximal, and proximal distal. So you'll see these 2 creases at the base of the thumb, proximal, and proximal distal, and our incision is going to be just distal and radial to the proximal distal. So that's where our incision will be. The pulleys between here and here. There's some things we want to look for before we start making incisions and before we slide the trigger tome in here. We want to get our trajectory across, and it's going to head towards the hook of the hamate, and we can find that by feeling for it many times. And I'm not really good at feeling it, and so the more exact way that I find the hook of the hamate is to use the ultrasound, and so we're going to do that here today. We're going to do a little ultrasound scan to locate some things. We're also going to locate where the radial digital nerve crosses over the tendon sheath, so we make sure that that's out of the way and we don't cut it. Okay, and so we're saving a picture here of a carpal tunnel. You can see the ulnar artery on the right side pulsating of the screen. We're scanning distally along the carpal tunnel, following the nerve, and I'm looking for the hook of the hamate, and it's showing up right. So here's the hook of our hamate. It's right there. I'm going back and forth. You can see it sort of on the right middle side of the screen, or the middle right. The median nerve's there. Hook of the hamate's right here. Ulnar arteries right there, pulsating above the hook of the hamate. So once I find that location, I'm just going to mark that with my marking pen where the hook of the hamate is, and that's the trajectory we're going to head with our knife when we make our incision. We're going to hold the thumb out extended, and we're going to head right across the hand. So I actually will mark that on the patient. So I'm marking that trajectory towards the hook of the hamate. Okay, so that's one of our lines. And then the second line is going to be where we find our radial digital nerve. So you're going to see our radial digital nerve pop up next to the tendon sheath on the left side of the screen here. So there's our radial digital nerve, and then next to it is the flexor tendon. And we're heading towards the palm, and you can see the nerve traveling over the top, and there it's right over the top of the flexor tendon sheath at that level. So I'm going to take this away and mark. This is where it's going to cross over our tendon sheath. Now our tendon sheath is right along this line. We're going to find it. We're going to find our A1 pulley. You can see our MP joint, and then you see the A1 pulley, which is thickened as I slide the device or the ultrasound probe back and forth. It's coming in and out of focus. So right here we're seeing the A1 pulley at the MP joint coming in and out of focus right there. So, and we're right along that line that we talked about before. So we're going to end up crossing over somewhere right here. So you see where the proximal thumb crease, proximal distal, and then where we're going to make our incision. You see the level of where the radial digital nerve is going to cross over our tendon sheath. Our tendon sheath is going to be along this trajectory that we've drawn here towards the hook of the hamate. which is right here, which we found just on ultrasound just now. We've already injected her with local with epinephrine. That's been in for about 15 or 30 minutes now, or more, and that's great. That's about how long we want it in there to stop the bleeding. I'm going to make a little incision, and again, it's just radial to the midline. And I'm going to drop in with my knife, and I'm going to drop right down to the tendon sheath with that, and go through it right there. I'm going to take my scissor tips and use those to go into the tendon sheath at that level, and then verify that with the ultrasound. So you see our scissor tips underneath the distal edge of the A1 pulley right here on the screen. I'm lifting up, and so I'm in the tendon sheath. So I'm going to leave those scissor tips in there. And I'm going to take my device, and I'm going to switch out the scissor tips to the tip of the trigger tone. And then we bring this to the side and drop our hand and slide up underneath the A1 pulley with the device. This is a very tight one. Tell. There we go. Getting a little one out there. I'm just going to check to make sure we're still heading in the right direction here, and in the right spot. So you see our tendon sheath and our A1 pulley, and then you're going to see the tip of our trigger tone underneath the A1 pulley here. I'm lifting up, so we're up underneath. We just got to slide it a little further forward in the sheath here. So here's the angle we want to be at, with the thumb slightly abducted to the side and extended. The correct insertional position of the device is at a 20-degree angle to the midline in the abducted thumb. We're heading across the palm towards the hook of the hamate. There's a little dorsal ball tip on this device that has to clear the skin. And so how I do that is I spin the whole device around and I slide it in further, and then spin it all the way around 180 and then 360 degrees, and that little ball tip on the back clears that skin, so the whole device is up underneath the A1 pulley now. So I'm just going to check and verify one more time that it's in place. Again, note the correct insertional position of the device at a 20-degree angle to the midline in the abducted thumb. In the correct location. So you can see our device underneath the A1 pulley right here. Flexor tendon sheath, A1 pulley. I'm lifting up. The pulley tissue is just above the trigger tone device. We do a short axis view to again make sure we see this trigger tone device inside the sheath, which we do. We wiggle it back and forth. I see it inside the sheath. I'm seeing our digital nerve, which is well to the left of the tendon sheath. We're actually more ulnar than radial with our device by just a little bit, which is good because we're going to avoid that radial digital nerve even just a little bit more. And we're in the center of the tendon sheath pretty much all the way to the tip of the device, which is where we want to be. So you see the direction we're going to head. Cross the hand with our device. I'm going to hold the thumb out in extension, and then I'm just going to pull and push at the same time. I don't push very hard, then I twist at the same time. I'm going to feel this gently go through the end of the A1 pulley, and then it's released. I felt it give, and now I need you to bend your thumb. Open it. Bend it. Open it. There you go.
Don't feel hot.
Good. Make sure now. Bend it. Hold tight, tight, tight,
I
tight.
tried, it's just so numb. I don't have any control of it.
Good. It's gone now.
Yeah, I don't feel.
Once the absence of triggering is confirmed clinically, a skin closure is performed using benzoin and a 1/4-inch steri strip. Patients return to immediate light activity. Release to full activity is in 3 to 7 days, including heavy lifting, golf, and tennis. In the author's series of 27 cases, follow-up ranged 2 to 16 weeks. Complete release was achieved in all patients with no infections, neurovascular injuries, or reoperations. The average return to full heavy activity was 4 days, with a range of 2 to 8 days.